So let me introduce Alex Tarnutzer, who you know from last week. He spoke on a rather clinical topic last week. Welcome back, Alex. Alex is a head of neurology in Cantonal Hospital in Baden, Switzerland, and he is also affiliated with University of Zurich. Alex closely collaborates with Dominic Straumann, who you heard this morning, and also Connie Weber. Alex, stage is yours.
Well, hi, Asif, dear colleagues. Thanks for the kind introduction. It's a great honor and pleasure to give you an update on a recent work I've been doing together, mainly with Konrad Weber from University Hospital Zurich. And the main focus really was to get well, math more into pattern analysis of peripheral vestibular disorders, and it's still something we're learning on, and we're day to day we're getting more of the details. But this is an update or what we achieved so far. So the focus really is on machine learning using hierarchical clustering and what kind of pattern analysis can be done for peripheral vestibular deficits. So disclosure is nothing really relevant for this talk. So what I would like to focus on is, I mean, vestibular deficits, they may arise from various disorders with distinct underlying pathophysiology and resulting impairments. And I enlisted just a few disorders which came to my mind or which I came across when focusing on this topic, including things like vestibular toxic drugs, Meniere's disease, schwannomas, autoimmune inner ear disease, and many, many others, as some listed here, and still many others to come. So, and in the last 15 years, I mean, we achieved a lot of quantitative diagnostic testing for getting detailed information on the state of the different peripheral vestibular sensors using video head impulse testing, using ocular WEMPs to get the different parts of the superior branch of the vestibular nerve tested, including so the horizontal and the anterior canal and the utricle, and for the inferior branch of the vestibular nerve, likewise using cervical WEMPs to get the saccule tested, and using head impulse test again for getting information about the posterior canals. So with this detailed mapping, we really achieved detailed information about all 5 peripheral vestibular sensors. And not surprisingly, with various underlying disorders, distinct patterns in peripheral vestibular loss emerge and may be associated with certain disorders. And this is why we really focused on this topic and hypothesized that the pattern of peripheral vestibular loss may help in identifying the underlying disorder. So the aim of our recent work really was to characterize patterns of peripheral vestibular loss of function and to correlate them with specific peripheral vestibular disorders, and to facilitate early initiation of disease-specific treatment and to potentially improve the outcome of the underlying disorder. So, as I mentioned, the focus of this talk is really about pattern recognition. First, I'll give you an introduction how pattern recognition works, and then we'll look at it in peripheral vestibular disorders. So in general, whenever it's about pattern recognition, it's a type of clustering data. So the task usually is to identify similar groups of data in a data set where the number of groups as well as their forms are unknown. So clustering is an unsupervised machine learning approach. This is an example. On the left side, you'll see unclustered data, and after having run a type of clustering, you'll see that here the algorithm proposes that 3 different clusters of data actually can be extracted from this initial cloud. So in general, it's about gathering the data, clean it from noise, examine it for similarities, group data into segments, analyze those segments, and then obviously implement insights. But how does this approach work? What options do we have? in general, there are 4 standard steps of processing in the processing or in the clustering algorithms. The first really is that you have to extract the features of your data and decide on the selection to define which are the most representative features of the original data set. And then you'll have to go on to the clustering algorithm design. So design the clustering algorithm or choose from a huge variety of existing clustering algorithms according to the characteristics of the problem you would like to address. Third step is actually to do the evaluation of your results. Well, assess how well clustering actually performed and then judge the validity of the algorithm applied. And in the end, give a practical explanation of the clustering result you've achieved. Does it actually make sense to the data you had collected? So all clustering algorithms, they're based on aspects including the distance or dissimilarity and the similarity of between single data points. This is really the basis for constructing clustering algorithms. There are more than 100 clustering algorithms known. However, few are used popularly. So I enlisted a few types of clustering. There are connectivity models, including hierarchical clustering algorithm, which we'll look at more in detail later. There are centroid models, for example, k-means clustering. There are distribution models, density models, and many others. So connectivity models either start with many clusters that are aggregated as the distance increases, which is referred to as agglomerative clustering, or a single cluster then is partitioned as the distance of data points increases, which is referred to as a divisive connectivity model. Here in this graph, you'll see an example of an agglomerative clustering approach, where actually those single data points get clustered more and more based on their similarity and dissimilarity. And what you end up with often is then such a dendrogram, which in the end you can use to achieve a representation of the similarity or dissimilarity of your different clusters as shown here. In contrast, there are centroid models, for example, k-means clustering, and here it's the center of data points that are referred to the center of the corresponding clusters. And you'll actually, what you need to do in this type of clustering, you need to define the number of clusters. And in the example I'm showing you here, it has been decided that there are 2 different clusters, and you'll actually just start with randomly assign each data point to one of those 2 clusters. So it's either red or gray here, and you then compute the cluster centroids, the 2 axes you got here. And in the next step, you reassign each data point to the closest cluster centroid, you recompute cluster centroids, and you repeat this until no further improvements are possible. And by this, you get an optimized clustering analysis using k-means clustering. But as I said, here you need to define, before you actually start the analysis, how many clusters you will end up with, how many clusters there are. So, as I mentioned, you have different choices to make. And one choice is the distance measure you would like to apply. And there are multiple distance measures or metrics which can be selected for deciding the closeness of 2 clusters. I don't want to get too much into detail here, but I just want to give you an impression how huge the selection is. There is one type of distance measures called Minkowski distance, with again many different subtypes, including Euclidean distance, which is fairly often used. There is standardized weighted Euclidean distance, Pearson correlation distance, cosine distance, and Mahalanobis distance, and many others more. And they all have different approaches in defining how to determine the closeness of 2 clusters. A second choice you have to make is the linkage criterion, which actually specifies the dissimilarity of sets as a function of the pairwise distance of observations in the sets. And again, many choices you can make, or in the huge selection you have, there are different linkage methods ranging from simple single linkage to complete linkage, average linkage, centroid methods, Ward's methods, which all have their advantages and disadvantages. Again, it's a choice you need to make before starting your cluster analysis. So after having given you a short summary or overview what types of clustering there are, I would like to focus on hierarchical clustering. Why picking hierarchical clustering? It's not just because it's popular, but it has a few very neat advantages and gives you a lot of flexibility. But again, you also have to make choices, and you can choose either wisely, or you can make, well, not that smart choices. So hierarchical clustering, I showed you before there is agglomerative approaches and divisive approaches, and it's the agglomerative approach which is much more frequently used and which we also implemented for the clinical data analysis. So it really builds a hierarchy of clusters, and initially all data points are in distinct clusters, as you've seen in the example I've shown you, and then the nearest clusters are merged into the same cluster, and it terminates when only one cluster is left. And here on the left side, you will see an example of such a clustering algorithm, and the dendrogram you actually receive starting from the bottom and going further up by decreasing the number of clusters. Now you have to make a first decision, namely when to stop, at which point you decide, well, these clusters are most reasonable. You don't want to end up with a single cluster. You would like to have a few clusters which are representative and clearly distinctive. And this is a choice you need to make, and it's an arbitrary choice. And this is one of the potential downsides of this hierarchical clustering algorithm. Here, the choice has been made at the level of, as you can see, four large clusters for type B. And when you go one further up for level A, it's only 2 left. So you have to make your choice. Next step, which is very important in any clustering analysis, it's about illustrating the data. You usually work with very large data sets, as for example, gene analysis, as here in this example shown on the right side. And if you do like a classic plotting, you will end up with many meters of paper. And one way that actually showed a very neat approach in illustrating such data sets in a very condensed and still very illustrative way is the use of clustered heat maps. And here on the right side, you'll see an example of such a heat map, and we'll see more heat maps when I'll show you the data we assessed. So it allows to really compact large amounts of information into a small space, and it brings coherent patterns in the data. And so it's become very popular in illustrating mixed molecular data, but can be used for any type of data sets. And again, you'll see here the dendrogram as part of such a clustered heat map. So as I mentioned, there are limitations in the visualization of massive amounts of genotypic or phenotypic data. So when you use clustered heat maps, you usually get an impression of first order insights into data only. So there might be nonlinear relationships which are present in a subset of the samples only, and they usually don't show up, and you actually may miss them when you do your clustering analysis. You also have to decide, well, in the cluster tree, bifurcations can be swung into either direction. Objective, but to some degree arbitrary rules must be invoked. And a large number of choices have to be made. As I mentioned before, you need to decide on the pre-processing algorithms, on the clustering algorithms, on the distance metrics, and also on color schemes when using the heat maps. So the selection of variables is essential, and if restricted to small subsets, you also risk to do cherry picking analysis and to lack of robust statistical power. Nonetheless, I mean, it's important to keep these limitations in mind. Hierarchical clustering analysis using clustered heat maps turned out to become very popular and powerful in data analysis. And so this is why we decided to use this kind of hierarchical clustering to assess our data sets. And this is what I would like you to present in the second part of my talk, mainly to identify patterns in a vestibular testing battery, including video head impulse testing and ocular and cervical VEMPs that was applied to patients with either unilateral or bilateral peripheral vestibular deficits. Those two studies were built up in such a way that two independent reviewers rated the overall function, either being normal or abnormal, of each vestibular organ based on the testing we had available. Namely, for the video head impulse test, this was the AVR gain, cumulative saccadic amplitudes, and the overall shape of the AVR response. And for the VEMPs, it was really the asymmetry ratio with a cutoff of 30% that one side was considered hyperfunctional. We also retrieved clinical information, including underlying disease, disease duration, age, and gender, whenever available from the patient's medical files. And we then correlated the vestibular patterns with the specific underlying disorders. We did this separately for unilateral and bilateral vestibulopathies. And first, I would like to show you the results for the bilateral vestibulopathy cases. This was a case series with about 100 patients. Most of them, the majority, actually had no identifiable underlying disorder, whereas from those where we could identify a specific disorder, it was mostly vestibular toxic drugs leading to bilateral vestibulopathy, bilateral Meniere's disease, or inner ear infections, and many others less common disorders. And what you can also see from this graph here, the number of affected sensors. And remember, it's 5 sensors on each side, both sides that were involved. So it's from 1 to 10 sensors, or well, 2 to 10 sensors which had to be involved. You'll see that depending on the underlying disorder, the average number of affected sensors varies quite a bit, and these differences were also statistically significant. So this is an example of such a bilateral vestibulopathy in Meniere's disease. As you can see here, it's the left anterior and left horizontal canal which show loss of function, and at the same time on the right side, it's only the right posterior canal. And at the same time, it's also the OVEMs which were significantly asymmetric, and the CVEMs which were bilaterally absent. So showing quite extensive disease in this patient. And so we did this overall rating for all the patients with bilateral vestibulopathy for all the different canals. And what you can see here in this hex plot is that, and dark gray is the fraction of patients, patients which had normal function for this canal. For example, for the right anterior canal, it was actually the majority, which was still normally functioning, same for the left anterior canal, whereas for the horizontal and posterior canals, the largest part of patients really had loss of function in these canals. So it's not surprising that average gains were larger for the anterior canals, and that cumulative saccadic amplitudes were smallest for the anterior canals. So these are patterns which already kind of emerge when looking in a classical way at the data we obtained. But we then went one step further and actually applied hierarchical clustering analysis using Euclidean distance metrics and average linkage, and built a heat map and an accompanying dendrogram. And when you look here on the bottom part, what you can see is that we managed to identify 6 large clusters where patients had similar patterns of peripheral vestibular loss. And I would like to have a look a little bit further on that. What you actually can see when you look at the dendrogram structure is that for all instances except one, the identical sensors on the left and right side merged first. This was true for all sensors except for the utricles, where the 2 utricle organs actually merged later. And mergers between the different vestibular organs occurred first for the posterior canals and for the horizontal canals, and then with the right utricle. The next level, the saccular organs were added and the anterior canals were added last. So the anterior canals actually were the most distinct from the other peripheral vestibular sensors in their behavior of being either normal or abnormal. So, and if you then look at the different nodes, you can see that the nodes we identified, they had specific characteristics. So, for example, node A, it was the state of the saccular organ being spared in all patients that actually was key for this node, where patients with sparing of the saccular organs and the posterior canals were assigned to node B. Node C was focusing on the anterior canals and the saccular organs remaining intact, whereas it's node D where those patients were assigned to where the anterior canals remained intact and all other peripheral vestibular sensors were affected, whereas node E had an impairment of all vestibular sensors, and node F kind of was a bit of a mixed bag. So with those different patterns now identified, obviously the question was, well, do we see an enrichment of certain disorders in given subgroups? And what one could see there is, well, different things. First, there was really a huge range from going from isolated impairment of the posterior canals to sparing of the anterior canals and or the saccular organs to loss of function of all vestibular end organs. And therefore, the cluster analysis further emphasized the broad spectrum of canal and otolid organ impairment in patients with bilateral vestibulopathy and emphasized that certain disorders go along with certain patterns in bilateral vestibular loss, and most obvious such a linkage was for those patients with aminoglycoside-related vestibulotoxicity in the node with anterior canal sparing, node D, where we had a clear enrichment of this subgroup. So for this patient group, it really was a huge advantage to have hierarchical cluster analysis as part of the overall data analysis. And I'll show you a second example now with patients with unilateral vestibulopathy, where we had a similar, where we could actually do the same approach and get a similar and again, very helpful result. Here it's a group of about 300 patients with unilateral vestibular disease. Again, different underlying disorders, most frequently acute unilateral vestibulopathy, unilateral vestibular schwannoma, patients with episodic vestibular syndromes, and other disorders less frequently found. We extracted those video head impulse tests from a large VHIT database, and as I said, ended up with about 300 data sets we could include for this study. Again, an illustrative example. This is a patient with acute unilateral vestibulopathy affecting only the superior branch of the left vestibular nerve, and matching the pattern with OVEMs being affected on the left side and CVEMs being symmetrically intact. So again, we looked at the relative frequency of semicircular canals with hyperfunction, and note for illustrative purposes and for analysis, all affected, well, it was always the right side which was affected. So it must be 0% with affected canals on the left side here. So as you can see, it was the horizontal canal which was most often involved, and where also the gains were kind of most clearly reduced, and where we had the largest cumulative saccadic amplitudes. So again, it's already kind of showing here that the different canals are involved differently and to a different extent. Again, when you look at the number of affected sensors, now ranging between 1 and 5, you'll see that amongst the different underlying disorders, averages are clearly different, with being statistically significant for many pairwise comparisons. And when we then plot this distributions in a polar plot, where you can actually see what's the condition ranging from all 3 canals to horizontal and anterior canals and other combinations, and then always looking, well, are both utricle and saccule involved? Is it just one, or is it neither? You'll see where the largest data sets were, mainly only involving the horizontal canal, but also involving all 3 canals and both macular organs, and here also horizontal and anterior canal and the utricle. So it's we thought it's a very nice way to get a first impression on the distribution of data sets. We then applied this to all subgroups, disease-specific subgroups, and again, you'll see certain patterns are much more frequent than others, which is kind of true for most disorders shown here. For example, here the acute cochlear vestibular neuropathy, where it's usually all 5 sensors, or most often all 5 sensors that are involved. So again, we did the hierarchical cluster analysis, applied heat maps and dendrograms, again using Euclidean distance metrics and average linkage. And again, we identified several nodes where patients assigned to these nodes had a similar pattern or the same pattern of peripheral vestibular loss of function. Let's look at the dendrogram structure again. So what you can see here, it's that mergers occurred first for the posterior canal and the saccule, for the anterior canal and the utricle, and last, the next step was really that these 2 pairs merged, and only last there was a merger with the horizontal canal. So the horizontal canal had the most distinct state to all the other peripheral vestibular sensors. And now let's have a look at the nodes we identified. So node A was the state of the horizontal and posterior canal being impaired in all, whereas in node B, it was the state of the posterior canal, and node C, it was the state of the anterior canal being intact in all. And here we also see what the most frequent underlying disorders were. So for example, in node C, it was the vestibular schwannoma and acute unilateral vestibulopathies that most frequently found in this node, where for node D, it was an isolated impairment of the horizontal canal and the utricle, and in node E, it was an impairment of the anterior and the horizontal canal and the utricle, which is the classic superior branch vestibular nerve pattern. Node F had an involvement of all 5 sensors, and node G had an isolated impairment of the horizontal canal. So again, using cluster analysis, we could identify different underlying patterns. And again, there was a huge range going from isolated impairment of the horizontal canal to sparing of the anterior canal to loss of function of all vestibular end organs on one side. And again, it really helped to extract and illustrate the broad range of vestibular end organ damage across our study population. And again, certain diagnoses were enriched in the single nodes, and this was most consistent with acute unilateral vestibulopathy, representing 34 out of 37 cases with impairment of the anterior and horizontal canal and the utriculus, while the sacculus and the posterior canal were spared. This pattern, as I mentioned before, really follows the innervation of the inner ear. So, in conclusion, there's a huge selection of clustering algorithms. So consider consulting an experienced statistician before you actually choose which type of clustering you'd like to perform. In our case, in the two studies I've shown you here, hierarchical cluster analysis was successfully implemented, and it significantly facilitated pattern recognition and emphasized the broad range of vestibular end organ damage across the study populations and subgroups. So further studies, there's still a lot of work to do, should further standardize the validation of clustering results and judging on the suitability of the selected algorithm. And one also needs to focus on eliminating limitations of currently used clustering algorithms, including all those arbitrary choices I've mentioned before. So this is the hospital I'm working on right now, and it's also at the same time the end of my talk, and I'm happy to start discussing and getting your feedback. Thanks a lot for your attention.
Thank you, Alex. Sergio.
Do you have an explanation about the frequency of lesion in the horizontal canal in comparison with the others?
Well, it's hard to tell. It could be that it's really easier to be testable. I mean, it's more difficult to get the vertical head impulses done. You'll use lower peak head velocities, so it could be less sensitive to the vertical canals. It could also be a selection bias that patients might more likely to be to go to the hospital when the horizontal canal is involved. I mean, time constants are different for the different canals, so it could be well, many explanations. I don't have a favorite one, but it's a striking enrichment of the horizontal canal. We had the same discussions about the anterior canal, especially in the bilateral vestibular loss patients. So something which actually one would like to study prospectively. This is all retrospective data.
Interesting.
That was great, Alex.
Thank you.
So you could apply this in a way that if you were selecting cases in the emergency department, you could at least recognize the one that fit the algorithm and then leave the ones out. They will need to be analyzed and undergo a workup. But the way it is showing here, the application is huge, you know, because we're trying to recognize patterns that will be safe, quote unquote.
Yes.
Right? And if you get 3 or 4 patterns that are really common, then you're all set. You can, almost anybody can do a good triage in the emergency department. That's great work. Very nice.
Thank you. Thank you. Yeah, I mean, I have to admit, I mean, it's not that easy really to implement in the emergency room, right? I mean, head impulse testing, yes. I mean, video head impulse testing, yes. But getting the VEMPs done in the ED, well, I haven't come across a hospital that could implement that. So
You can do LRM, and then you can have some predictable, some predictors. And then you get rid of VAMP, and then you just go by the predictors. You know what I mean? So, so which is the most likely predictor of this? 1, 2, 3, and 4, and then complement this with cluster. Alex did not say that the work that he presented, which just got accepted in Green Journal not too long ago. Is it already on PubMed or not yet?
Yeah, it's on PubMed. It's in it should be in the printed issue. I think early December, but it's all available online. I think it's not yet the final printed version, but it's all available.
Machine learning is a new way to do things now, I guess.
Yeah, we're still learning a lot. So not only the machine.
Yeah. Great.
Okay.